Good morning, everybody. My name is Jody DeLay, and I am the Education Support and Advocacy Manager for the Northwest chapter of the Crohn's and Colitis Foundation. I'm so thankful to have all of you here this morning. Like some of you, I've felt a little burdened by all of the crazy changes that we've had to make in our lives, and I have to say, I'm really proud collectively of all of us of how we've adapted and sort of stepped up to the plate to try to hopefully come out of this whole event, this whole year, even stronger. And I have to say, in particular, I'm really, really thankful that we've had to think out of the box a bit and sort of reinvent the way that we do things. And so I'm actually super excited about this program, in that we have people that have registered to watch the video library from all across our region. So we have Alaska, Oregon, Washington, Montana, Idaho. I'm really happy that some of my Montana friends, some of you know I came here from Montana, are gonna hopefully join this morning, but if not, have definitely been enjoying the videos. So I think that's a real advantage of this format. And I wanna welcome you from wherever you are. We actually also have someone who registered from California and from Maryland. So we're nationwide today. Let's see. So I also have been just really incredibly grateful for our chapter medical advisory committee, who has just been willing to kind of look at what we can do and ways that we can make this work, and been willing to just put themselves out there and give whatever we come up with a try. So I'm really thankful to all of you. Some of you are on this call, and I just really feel like if wherever you are in your IBD journey, that you're in good hands, because the professionals of all layers of care that are involved with this disease just really care about your well-being and health. So we are fortunate to be in good hands. So with that, I'm going to go ahead and get started. I have just a couple of slides that I'm going to share with you here, if I can make this work.
No, it's shared.
Yay, hey. Let's see, now I just want to actually start this.
Oh man, you had to use that photo?
First, we're going to just share our mission, because I think it's always good to come back to this. The Crohn's and Colitis Foundation exists to cure Crohn's disease and ulcerative colitis, and to improve the quality of life of children and adults affected by these diseases. And I think this is the reason that we decided that regardless of not being able to meet together, we needed to do this event. We needed to I don't have this started, do I? We needed to provide the resources to our patients and their caregivers. So we're really hopeful that the video library will be watched a lot and be accessible sort of on demand going forward. We could not do this educational programming without our community partners. Some of them are on the line today, and I just want to send out a real big thank you to Janssen, Primera, Blue Cross, Seattle Children's Hospital here in Seattle, Swedish Gastroenterology, Takeda, and Washington Gastroenterology. So a couple of Zoom protocols that we'll look at today. We are recording this presentation. We may or may not share it depending on how everything goes. We do want you to feel comfortable to speak up and ask your questions. There's a couple things that you could do if you want to maintain a little bit of anonymity. You can click on your name in the participant list to change your name. So you could say, change your name to IBD Warrior or something, and then it won't show up in your box. You can take your camera off, although we would love it if you would turn your camera on. One of the things that the online forum does not allow us is this ability to interact with one another. And so this Zoom allows us a little bit of that. So if you're comfortable, please turn on your camera. And if not, that's completely fine. Do not worry about it, it's totally okay. You can ask questions out loud. At the bottom of your toolbar on Zoom, there is a button that will allow you to raise your hand. And that way we can sort of keep track of who's next. It's not completely necessary that you do that, but it can be helpful. If you need to just speak, that's okay too. And then you can also send your questions directly in the chat if you prefer not to ask them out loud. So I'm going to go ahead and turn it over to Dr. James Lord, who's out of Virginia Mason Medical Center and Benaroya Research Institute. He is our chair of this program and has been awesome. Along with other committee members, he helped us review the presentations and such, and just helped come up with this crazy idea to try this video library, video club format. So with that, I am going to turn it over to James.
Thank you very much. So for this first hour, we're going to be featuring three main topics, which hopefully you've had a chance to review the videos. And if not, certainly feel free to ask any questions that are specific to those topics. Our topics for this first hour are inflammatory bowel disease and COVID-19, featuring my close colleague, Elisa Boden. We're both at Virginia Mason. Maintaining resilience during the pandemic, that was recorded and presented by Skye White and Allison Doyle. And then talking about what is remission and the concept of treating to target, which was presented by Alina Wong. And so we have all four presenters here this morning. Yes, I see you all. And I'll introduce them and then we will get started. So Dr. Elisa Boden has been a close colleague of mine. We actually shared an office for several years. We recruited her almost a decade ago to Virginia Mason from the East Coast. She specializes in inflammatory bowel disease, and her area of expertise include Crohn's disease, ulcerative colitis, but she also has become an expert on celiac sprue and other immune-mediated diseases of the gastrointestinal tract. In addition to being an outstanding clinician, Elisa Boden is a fantastic basic immunology scientist. She actually comes from a number of the biggest, most impressive labs in the country. So she's trained with the real leaders in understanding how the immune system causes inflammatory bowel disease. So she has been a very valuable colleague to me over the years. And so I'm going to take this opportunity to say that she is actually planning to move down to Oregon at the end of this year and will be joining the GI community in Portland. So I'm sad to see you go, Elisa, but I think that Portland is going to benefit dramatically from your presence. Allison Doyle is a licensed and independent clinical social worker. She's a therapist at Catalyst Counseling in Woodinville, Washington, across the lake from us. She works with individuals with chronic illness, self-esteem, and body image issues. She's also involved with the LGBTQIA community, and she has experience working in psychiatric and medical settings, mostly with individuals experiencing significant medical trauma and acute psychiatric crises. Skye White is a licensed independent clinical social worker and therapist at Catalyst Counseling in Woodinville also. So she works, in addition to working alongside Allison Doyle, with older adults, individuals with chronic illnesses, life transitions, and also members of the LGBTQ community. She has experience working in medical and social service settings with individuals experiencing homelessness and survivors of domestic violence. And Dr. Alina Wong is a general gastroenterologist specializing in inflammatory bowel disease at Swedish Medical Center. She completed her internal medicine residency at Stanford and did her gastroenterology training here at the University of Washington, where I met her when she rotated through Virginia Mason. She is a member of the Northwest Chapter Medical Advisory Council for the Crohn's and Colitis Foundation. And we're happy to have you all contributing your Sunday mornings to answer questions. And I am particularly appreciative of the fact that we were able to record all of your presentations in advance and create a resource not just for this morning's event, but for the foreseeable future, as I anticipate that what we do today will be a small fraction of the benefit that will come from the presentations that you created going forward. So we're going to get started this morning with Dr. Boden. Elisa, do you want to make any comments about your presentation, IBD, COVID-19, before we go through some questions?
Yeah, I know this is a topic that's been on everybody's mind. And, you know, I wanted to remind everyone, as I did in my presentation, that things are really evolving pretty rapidly with our understanding of this topic. So while I tried to be as complete as possible in putting together what we know about COVID and IBD, I think things are likely to change in the future. And I want to encourage everybody during this time to stay in touch with their healthcare providers, because I think new information is going to come out, you know, over the course of the next few years. And I also think it's a vulnerable time for patients, and we need to make sure that we're keeping people in the loop for their health care for routine things for inflammatory bowel disease as well. So I'm really excited to talk to you guys about what I learned about COVID-19 and inflammatory bowel disease. And again, just a plug for everybody to try to stay engaged with their healthcare providers so that they can be as up to date as possible on this topic, and also so that they can stay healthy during the pandemic.
So in contrast to historically how we have had these conferences organized as largely a didactic environment, Jody had the bright idea that this would be more like a book club where all of the information was available in advance for you to peruse. And then the meeting itself was really an opportunity for the audience to ask questions and learn more about what made them curious about the presentation, what they didn't understand. And so really the main purpose here is not for us to speak, but for you, the audience, to speak and see what we can do to fill in the gaps. So at this point, please be very forthcoming with any questions you might have on your minds about COVID-19 and inflammatory bowel disease. And of course, you have to unmute yourself if we're going to hear you.
James, do you want people to raise their hands?
Yeah, although I personally couldn't figure out how to do that. So if you just want to unmute your mic at this point, or Jody, do you have a better idea of,
Yeah,
I can't find the...
Definitely feel free to just take off your mute, but if you just run your mouse over the bottom of the screen, there should be a button that says reactions.
Oh, it's the reactions button.
And
okay.
If you click on that, it gives you a couple of choices. Oh, and I guess it's not actually a raise your hand, but you can give a thumbs up or...
Oh yeah, it's clap or thumbs up. That's all it is. Okay, so I couldn't find it.
but feel free to just ask a question out loud as well.
Okay. Well,
do you want to ask me any questions, James?
Yeah, I'm actually surprised because this has to be one of the main things I get asked about in clinic lately is, as an IBD patient, my patients ask me, you know, what should I be doing? Do I need to worry? So the first question, Elisa, is the fact that there is a problem with the immune system in inflammatory bowel disease. That's probably how the disease happens. And we know the immune system both protects you from COVID-19 and potentially causes a lot of the dangerous problems of COVID-19. Are people with inflammatory bowel disease at increased risk, regardless of their treatment? Is the disease itself and its association with the immune system a reason to worry about COVID-19 specifically among patients with IBD?
So that's a great question. And I would say, we have a little bit of preliminary data on it, but I think overall we don't know that much about how inflammatory bowel disease interacts with this virus. We're starting to get some more information. So one of the really cool things, and I talk about this in my presentation, is that there is actually an international effort to try to capture patients with inflammatory bowel disease that develop COVID-19 and to generate some information on what happens with them when they get this virus, and who's getting the virus, how sick they are when they get the virus from their inflammatory bowel disease, what medicines they're on, and then what their outcomes are. Do they get really sick from it, or are they someone who gets an asymptomatic or mild infection? And because of this database where physicians voluntarily report their patients who have had COVID-19, we're starting to get a little bit of information out. So there are about 900 patients from around the world in this registry now, and it's growing and generating some initial data. What I would say is this, I think it's a very interesting question, because you're totally right. There's a couple of things that might make us think that inflammatory bowel disease patients would be more at risk to even catch the virus. I guess that's the first question, right? Do they catch the virus more than people who don't have inflammatory bowel disease? And I think one of the things that this is a question that's really hard for us to address, right? Because some people catch this virus and don't have any symptoms related to it. So we only really know when we look at inflammatory bowel disease patients who catch who catch COVID, if they had symptoms and were tested because of those symptoms. So it makes it a little bit hard for us to research that. Now, there are a couple of things that may put patients at higher risk. So one that you talked about was what medications they're on, and you said you didn't want to hear about that, and we can talk about that a little bit later. So patients with inflammatory bowel disease may be on immune suppressing medications that might increase their risk of getting a virus or getting a more serious infection from a virus. And we know that some of our medications put patients at risk for other types of viruses. Things like cytomegalovirus or EBV. These are other viruses that people on certain medications can be more susceptible to. The other thing is that when people are really sick with their inflammatory bowel disease, they may, their immune system may be even further suppressed. We think the immune system gets off or is off in people who have inflammatory bowel disease, and that's what causes them, at least in part, to get the inflammation that doesn't control itself. And so patients may be at risk just at baseline, but also when you're really sick because you have inflammatory bowel disease and your nutrition is not good, or the barrier function of the intestine is broken down. And we know that this virus potentially can bind to some receptors in the gut and potentially gain access to the gut, although that's never been proven. So, I think there's a lot of reasons to predict that our patients might be at higher risk. However, there have been preliminary studies where they basically just looked at the overall population to see whether patients with inflammatory bowel disease were more likely to be reporting infection with COVID-19. And those studies have not shown an increased proportion of the population getting COVID-19 has inflammatory bowel disease. So
now what? Sorry.
Yeah, that was a long-winded answer, but I think the bottom line is there's no data suggesting that patients are at higher risk for developing the disease.
Now, I want to differentiate that from another aspect. So your immune system helps protect you from getting an infection. And if anything, the immune system in IBD is probably hyperactive. So in that setting, perhaps IBD may even be slightly protective. But we keep hearing on the news about this thing called cytokine storm that happens when people get really sick with COVID and start to develop all of this lung disease that makes it hard to breathe and puts them in the ICU. Because inflammatory bowel disease is associated with so much immune activity, and immune activity is a cytokine storm of itself, are people at IBD, once they get COVID, more at risk of having a severe course from COVID-19 and more likely to get into the ICU and suffer some serious consequences?
So that's another great question. So from the Secure IBD database, so that's this database that we've all been reporting to, our patients who have IBD and have developed COVID-19, they actually looked at that question. They had about 500 patients, and it did not look like patients with IBD, that the IBD itself was a risk factor for getting more severe disease. It looked like the same things that are risk factors in the general population, which are age and other disease illnesses, seem to be the things that make people at higher risk for severe disease.
Another thing we've heard about in the news is that one of the first drugs that was shown to save lives in COVID-19 was dexamethasone, which is a steroid, very similar to prednisone or budesonide, drugs that we use to treat IBD. So even though it sounds scary to be taking a medication that affects your immune system in the middle of an infectious pandemic, are some of the drugs that we use to treat IBD potentially protective?
So I think that, there's been a lot of data out there about steroids, that they help and that they hurt in the general population when treating patients who have severe COVID infections. And I think we don't know the answer to that question outside of the IBD population. Within the Secure IBD database that was reported, again, these first 500 patients, being on steroids was actually a risk factor for having more severe disease and death. And so it is the one medication, again, for multiple reasons, but first because we know that it doesn't, in the long term, help patients with inflammatory bowel disease. It's really a short-term fix for people who are very sick. So we probably shouldn't be having patients on steroids for a prolonged period of time. And really, I'm talking about systemic steroids like prednisone, things that affect the whole system. The question of budesonide, we don't know the answer to. So budesonide is a steroid that mostly gets absorbed and treats the intestine, and then gets broken down by the body, so your body doesn't see a high steroid dose. So we're talking about mostly patients who are on prednisone, but those patients actually did worse. And so in my practice, I'm really trying to minimize steroid use. I will say there's a little bit of a problem here in differentiating those patients who were on steroids from other patients with inflammatory bowel disease, because patients who were being treated with steroids may have been sicker from their inflammatory bowel disease, and that may have impacted how those patients did. And while the study tried to correct for those things, it doesn't do a great job of doing that if the patients in that group are very different in some way from the other patients. So I think there's a little bit of caution we have to use when we interpret the data from the study. Again, because we're gathering information as it comes in and not in the context of a very well designed and controlled study. But what I'm doing with my patients is really trying to limit prednisone to patients who absolutely need it for the shortest period of time, and then transition them to other medications for maintenance because of the data that came out suggesting that these patients did worse.
Well, I think the obvious follow-up question to that is, if not prednisone, then what? What medications are the safest medications in the midst of a pandemic? If we're not going to be using old-fashioned prednisone, then what should we be using?
Yeah. So we're really encouraging our patients to stay on their medications. I think, again, with this same registry, they looked at the anti-TNFs. So those are things like infliximab, Remicade, adalimumab, Humira, Cimzia, certolizumab, golimumab, Simponi. So those medications. And they actually showed that those patients had slightly less risk of having severe disease. Again, I think this needs to be interpreted with caution. But certainly those patients didn't seem to do worse. And there's some potential explanation for this in the sense that we think patients do poorly with COVID-19 because they do have this cytokine storm, this intense inflammatory response, and anti-TNFs may turn down that pathway. And so there is some potential explanation for this, but I think it's very reassuring for us that those medications do not seem to be associated with worse disease, and if anything, may slightly reduce the risk for serious disease. In the registry, there were very few patients on Stelara or ustekinumab. Those patients, interestingly, however, none of them had poor outcomes. So I think none of them were hospitalized and none of them died. But again, very small numbers, but also suggesting we're not seeing a big signal out of those medications. And we didn't see a big signal either way with vedolizumab or Entyvio. The other medications also, the only other medication that came up to have potentially a positive effect in this study, meaning patients seem to do worse on the medication, were actually the 5-aminosalicylate medications, so medications like sulfasalazine and mesalamine. And again, I really want to make sure we interpret these results with a lot of caution. I am not telling my patients to go off of these medications. Again, this may reflect the patient population that's most commonly treated with these medications because these medications are more commonly used in older patients. And older patients seem to be at higher risk to get severe infections with COVID. And also there may be differences in the way that physicians are reporting patients who are on 5-ASA or not reporting them. Because again, I think physicians have been very diligent to report those patients who are on medicines that we worry about, and potentially less diligent to report those patients that had maybe a mild or asymptomatic disease in medicines that we worry less about. And we don't really understand how the physiologic effect, how the effect of the medicine would make the disease worse. It doesn't make a lot of sense. So again, I am not telling patients to come off of those medications at baseline. I think if you get COVID and have a severe COVID infection and your IBD is well controlled, I might stop those medications just in case there is any interplay there. But I am suspecting that this is another one of those times where the patients who are on these medications may actually just be at higher risk at baseline.
So I'm seeing that there's some questions actually coming in on the chat. One of these you've already addressed. I'm on Remicade and azathioprine. Are either of these helpful or hurtful as far as COVID-19? I mean, you did address Remicade. Yes. Azathioprine?
We don't know. There didn't seem to be a big signal. I think what I'm doing, which is my personal style, which is in patients who are on combination therapy, I assess what the risk of their disease is. Are they in remission? Have they had a very difficult disease course where they might need both medications? Or if they're in remission and they haven't had a difficult disease course, I might think about taking off the azathioprine and leaving them on a single medication. But that's a style thing, and it's very important to talk to your own doctor about that. I would not stop any of your medications without discussing it with your doctor. So again, for combination therapy, we don't really know. I'm trying to streamline people's medications and reduce their risk in any way that I can. We don't know that much about 6-MP or azathioprine or methotrexate. They did not show big signals. But again, for combination therapy, you really want to assess why you're on it and whether you need to be on it. And if you don't need to be on combination therapy, you might think about taking off that second medicine.
Okay, and yeah, there was another question about Remicade in conjunction with methotrexate and its risk in COVID.
I would say the same thing.
Okay. Jody actually asked this one. You had mentioned starting with an injectable biologic to avoid having to come into an infusion center. Is it worthwhile to think if you're already on something that you have to come in and get IVs placed and go to an infusion center to get in order to facilitate social distancing? Should patients be considering switching from an IV drug like Remicade to an injectable like Humira?
So this is a great question. So we have some data that came out quite a number of years ago about patients on Remicade who actually switched to Humira, which is going from an IV to an injectable for convenience. And actually a very large number of those patients flared in their disease. So I think there are really risks for taking somebody who's on a stable medication in terms of disease remission and changing them to an injectable. They're not exactly interchangeable. So I would not do that. I would not take on the risk of changing someone who's on a very stable regimen. However, I think in the context of starting a new medicine, it's reasonable to think about putting them on an injectable and keeping them out of the infusion center or home infusion as much as possible. That being said, I think most places are taking very, very good care to socially distance patients when they come into their infusion centers. If you are getting infusions, it's just really important that you make sure that all of the good hygiene practices are in place and that they're separating patients and screening them for potential exposures before they come in. I would say it's not totally clear that home infusions are safer than going to an infusion center because, again, there's a nurse that travels from home to home. So there still is some potential for transmission of a virus. Again, though, if they're doing very good cleaning procedures, if they're distancing from their patients, they're pretty unlikely to transmit the virus. So again, I think patients who are getting infusions should continue with their infusions, that the overall risk is low.
This is a really interesting question here that hadn't occurred to me. So somebody wrote that there's an overlap in symptoms between IBD and COVID. Some things like diarrhea, abdominal pain, and fever have been associated with both IBD and COVID. Some employers are requiring symptom reporting and that you should stay home for a certain amount of days of experiencing any COVID-related symptoms. And so this question is wondering, could this be seen as discrimination if an employee is an IBD patient?
Well, that's a very interesting question. I don't know the legal ramifications of, you know, of that kind of discrimination. But I do think it is important, especially when patients are developing new symptoms of a flare, that they do get tested for COVID, because there is a possibility, there's a small number of patients who have symptoms that seem like an IBD flare that could be COVID. And so we obviously don't want those patients to be coming into work or interacting with other people where they might spread the disease. And we also don't want to be putting those patients on steroids or other things that could potentially make COVID worse. But I think there is a difference between having sort of stable symptoms from your inflammatory bowel disease and having a new set of symptoms. And I think it's reasonable to think about testing for that new set of symptoms.
There's another question about combination therapy, but specifically Entyvio and methotrexate. And given that there was a meta-analysis and a case series recently published about a month ago looking at combination therapy with biologics other than anti-TNFs, if you have a patient who's doing really well on a combination therapy like this, what are your thoughts about reducing the complexity of an immunosuppressant regimen in the setting of COVID?
Yeah, I'm thinking about it. I'm definitely thinking about that in my patients. I'm not sure that we need to be overly concerned. And again, there are high-risk patients who I would not take off their combination therapy. But I think if patients are in a deep remission, they've been doing well for a long time, then I do consider it and just closely following patients. And I think that's also a discussion that we have about risks and benefits, and everybody's individual threshold for wanting to change around their medications is different. So, but it's definitely a conversation that I have been having with my patients.
And somebody wanted to clarify your statements about steroids being a risk factor for COVID. You mentioned budesonide as probably not being as significant a risk factor, but somebody asked about topical steroids, so presumably rectally administered steroids.
Yeah, again, I think those are fairly minimally absorbed. And so again, we don't know, but I think that the risk is probably fairly low with the minimally absorbed steroids. So that would be like topical steroids or budesonide, Euceris, Entocort, those type of medications. Again, I am trying to minimize these though and not use them in the long term if possible. But for short-term use, I think they're probably low risk.
And somebody asked, how do you socially distance if a nurse has to put in an IV?
So you obviously can't socially distance completely, but making sure that both the patient and the nurse are wearing a mask, that the nurse is following all cleaning procedures, hand washing, that you wash your hands after that procedure, and just minimizing the time in close contact.
Okay, well, I think we've probably exceeded our time. Thank you, Elisa, for staying on for so long. Thank you for our other speakers for your patience to hang with us. But at this point, I'd like to shift gears and invite Allison and Skye to chime in with any comments on your presentations about maintaining resilience during the pandemic. And again, please, if you type in your questions, I will read them out as I've done. But you can also unmute your mic and ask questions frankly, at any time during this conversation. You don't have to restrict yourself to the speaker at hand, although certainly if anybody has to go on our speakers panel after they've presented, you won't be able to talk to them anymore. So Alina and, Allison and Skye, if you want to unmute yourselves, it looks like you are still muted, and maybe talk a little bit about the summary of your presentations, which are available in total online, and then we can start fielding some questions.
Yeah, thank you. Skye, I'll go ahead and just give an overview of our presentation if that works for you. We really just wanted to provide tools. We know that this time has been really hard for everyone, especially the IBD community and the chronic illness community. So really what we're seeing a lot from our patients is just really wanting tools, concrete solutions to really address the trauma we're all experiencing during this pandemic. Skye, do you have anything to add to that?
Just that, I mean, you know, to echo the trauma that we're all experiencing, right? I mean, nobody has really experienced a pandemic before. So, so we just wanted to have this presentation to talk about how to maintain resilience in the best way that we can. Give some concrete skills. You know, I know that coping skills are different for everybody, but we just wanted to address that it's hard to live in a pandemic, and especially if you also have a chronic illness on top of it. So, yeah.
Well, even before this conference started, there were actually a couple of questions that had been sent in. Oh, wait. Sorry, there was one very long question I'm going to have to dig through a little bit because I think there was something in it. Yes, so presentation on the topic of physical activity was very insightful. I found Katie Taylor's description of Crohn's disease as something that can affect your digestive system from lum to bum, the highlight of all the presentations. But the question I have, which I think she covered, but I want to be clear about, is it seems helpful for patients with IBD to engage in physical activity, and she was clear that it's okay that if you aren't feeling well to skip it, but conversely, is it okay to push yourself?
Was that for a different presentation?
Oh, whoops, I'm sorry.
Yeah.
Oops.
That's okay.
Sorry, my mistake.
No worries. I just wanted to make sure. We did suggest physical activity, right, as a coping skill, if that's something you really rely on and makes you feel good, right? That's something, I mean, with the smoke, we can't really do outside right now, but if that is something you're capable of doing, it would definitely be beneficial from a mental health standpoint as well.
I seem to have lost my Zoom window while trying to open that document. So Jody, I can't see the written in comments right now. So while I'm trying to, oh, there I do. Exit minimized. Okay, I'm back. So somebody was asking how to identify and reduce stress.
So just like, yeah. So, so stress can look different for different people, right? So it's kind of hard to give a blanket answer to how stress looks. But as I've been working with my clients and kind of identifying what stress and anxiety looks like to them, I kind of like to just think of it as baseline. So if you're feeling like more anxiety right now than you were prior to COVID, you know, like I'm just kind of, that's how I'm identifying it with folks. So looking back at how you are typically and if things are changing now. So stress a lot of times for folks can manifest in, like I said, anxiety, like inability to stop worrying. Also things like somatic concerns. So you might have like a stomach ache more frequently than normal. Or you might be more prone to feeling like irritable or just like having a hard time figuring out why you're feeling this way. So yeah, so I would say it's hard to say for everyone, right? But like looking back at how you typically act and how your body typically feels, and if it's feeling different now, maybe kind of trying to parse out what some of those are and if it could be mental health related.
Yeah, in addition to that, I think what the somatic concerns too, it can be, you know, sleeping problems, right? Like you're saying, irritability, if you're noticing that you're having a lower threshold patience-wise with your family, you know, kids, coworkers, I think it manifests a lot that way too. So reducing it, really, there's lots of strategies out there. It's not one size fits all. With my clients, I always tell them it's like throwing spaghetti at a wall, right? Like we're going to try a lot of things and we're going to see what works for you. Sometimes that's getting in a routine and making sure you're sticking with it. Sometimes that can be exercise. Exercise is a great stress reducer if you can and are capable of doing it, right, in a safe way, in a way that feels good. Meditation can really be great. And we live in the world where technology is bountiful. If you don't have access to, you know, a therapist to help you with guided meditations, right, there's apps out there that can really be beneficial, and doing it at home. And also working with a therapist, right, to getting to the root cause of what your anxiety is and what's coming up, and having that space for talk therapy can really be beneficial.
Mm-hmm. Well, there's a question here. I mean, part of the same question. Does an anti-anxiety, I presume an anti-anxiety medicine, help with lowering stress? So, I mean, this may just be through my lens as a prescriber, but I'm assuming this is asking about medications like benzodiazepines that are used as anti-anxiety pharmaceuticals. Do those actually help with lowering stress?
Well, I'll start with I'll start by saying that I'm not a prescriber. So, you know, I think it depends on, it probably depends on where your anxiety and where your stress is coming from. So if your stress is because of anxiety, maybe finding a medication to treat the anxiety can help lower the stress. But yeah, I would say that it's another thing that's pretty specific, you know, depending on where your symptoms are coming from.
Yeah, and I'll agree with Skye, and caveat, right? I'm not a prescriber. I'm not a physician. But there's also lots of different other medications other than just benzos too, benzodiazepines, that can help with stress too. So that might be something to explore with your doctor if your symptoms are unmanageable just with, you know, sort of doing the things that we were talking about, right? If they're feeling overwhelming and you're still feeling that sense of anxiety and stress and panic, right? It'd be something to talk to your doctor or your psychiatrist about.
I have a question that relates to your topic. So several years ago, a study was published that demonstrated that people with poor sleep, who, you know, self-reported low quality sleep, not a lot of sleep per night, interrupted sleep, a variety of different metrics for just measuring the quality of sleep, had a much higher rate of having acute flares of their Crohn's disease over the course of a year. Can you speak a bit to strategies to improve sleep hygiene? Because that is a vicious cycle where stress can result in bad sleep, and bad sleep results in worse coping skills for stress. And so how does one actually break that vicious cycle as concerns sleep and anxiety and stress?
Skye, do you mind if I start?
Go for it.
This has been coming up so much with my clients, and I love working on sleep hygiene with them because it's something that's really tangible, right? Something you can fix at home, wherever you are. And I think it's been really disruptive because of this pandemic, not just even with chronic illness and IBD flares and things like that. It's just really hard to turn off, right? So one of the things I really love to encourage my clients to do is to do a sleep journal, and to really assess what your sleep hygiene looks like. What does the routine at night look like? What does your caffeine intake look like at night? Really any other factors, right? If there's lots of sunlight, if you got lots of windows in your house, if your kids are part of that too, what does their bedtime routine look like? Does that make it harder for you to go to sleep? So really doing a journal, assessing what's going on in your routine at night. Also, how many times you're waking up throughout the night, what's waking you up at night, if it's just, not feeling great, right? Or if there's stress coming into it, you're waking up with thoughts in your head, right? And then also waking up, and what are you doing to try to get yourself back to sleep? Are you just struggling to get back to sleep? Are you laying in bed, tossing and turning? Are you doing something, right? So I really love the idea of a sleep journal to really get at the root cause, right? And make some really tangible adjustments to your sleep hygiene routine.
That actually sounds very similar to what we in clinic advise people to do concerning diet. People are so variable in terms of what the problems are that they deal with, that the most important thing is to collect data and just find out if you can play scientist yourself and determine what the causes are. Because if you find the cause, you can probably find the solution.
Mm-hmm.
So a couple of new questions that just came in while I was asking my question. What do you tell people about media input? Oh my goodness, we are just drowning in hot breaking catastrophes on the news on an hourly basis. What do you tell people to manage in this world of the overwhelming news cycle?
I can start. That's okay, Allison. So I have a really simple thing I tell folks, and it's limit your media input. And usually I have folks sit, I mean, you know, it's so easy to access the news right now. And I mean, like between all of the different devices and everything we have, but if you can set aside, like, I don't know how it might look for you, but if you do 30 minutes of the news in a day, maybe you could do like 15 in the morning and 15 in the evening, or like, you know, however that looks for you, but essentially just limiting it, because we get inundated so easily, and it's really hard if you're like constantly checking your phone to turn that off. So I usually just suggest like set aside a time in your day for the media input and then turn it off after that.
Also, utilizing your phone too. Your phone probably has timers for social media. I suggest that to a lot of clients. If that's too hard for you to sort of self-monitor, to actually have a timer on your phone.
Here's a question that actually ties together your subject with the fact that, you know, as per Elisa's subject, we're in the midst of a pandemic where over 180,000 Americans have now died. Fortunately, less so in the Pacific Northwest than other parts of the country. But somebody asked, do you have any suggested resources for dealing with grief and loss?
Yeah. I'll go ahead and start, Skye. I think one of the things that's really tough right now, right? There's a lot of, not only are we physically losing people, right? People are dying from this illness. We're also having a lot of ambiguous loss, right? There's the loss of our normalcy. There's the loss of just, you know, going to work every day, or your kids going to school and maybe they were supposed to graduate and you didn't have a graduation, right? So there's the tangible sort of physical loss of human life. And then there's also this ambiguous loss we're having to deal with. As far as grief and loss goes, I would highly suggest you find a support group. I think that those can be super beneficial, especially in a time where we're really distanced, right? And don't get to communicate with our loved ones. Making sure you're communicating with your family if you've lost a loved one due to COVID-19. Some tangible thing I think you could do on your own too is I really love the idea of people writing letters to their loved ones to sort of process. That's something I've been suggesting a lot to people, even with ambiguous loss too, sort of writing out what does that look like for you and what does that process look like?
And this same question also included a second part, wondering about the compared effectiveness of telehealth versus in-person therapy and whether there's any data on this. I gave a talk a few months ago, which is still available on the CCFA website, that talks about telehealth for an allopathic, you know, prescriber's clinic like my own, but I did not address the effect of telehealth on the type of practice that you, Skye, and Allison are performing. And a big difference here, and actually a reason why more psychologically oriented care has been a focus for telehealth, is because in my case, I'm often bringing people in because there are things like colonoscopies and physical exams that you can't do through telehealth. So we kind of have an out in my practice. But I imagine that what you're doing has become dominated by online resources lately. And what effect have you seen that have on your ability to treat the problems that you address?
I find it just as effective. You know, I mean, of course there's no substitute for being in person, right? But I've been able to adjust my practice just fine, and I find great success with telehealth with my clients.
Mhm. Yeah, same here. I think that that's been a pretty actually smooth transition, right? And it takes a lot of the stress out of doing something for yourself, right? Going to a therapist is really a way of taking care of yourself. And taking some of the stress away from that of meeting in person, maybe with masks on, having to get there, things like that. So.
Well, in that case, this is one good thing that may be coming out of the pandemic, because it's certainly more convenient to provide healthcare over the internet than to deal with the logistical obstacles that we normally do.
Yeah.
So somebody asked, does the Crohn's and Colitis Foundation have a list of therapists who are familiar with Crohn's and problems associated? This person was looking for a therapist, but one who can see how Crohn's affects her or him, along with the current politics, election coming up. By the way, please vote, etc.
I'll answer that. We don't particularly ever recommend a specific provider. I would say that Allison and Skye have some direct knowledge of chronic illness. That's a specialty. That's kind of why we went there. But we do recommend that you just find someone that you're comfortable with. And sometimes that takes a little bit of trial and error, speaking as someone who's used counseling. There's often somebody that you just click with, and then there could be another person who's completely qualified and wonderful that isn't as good of a match. And so the counseling world seems to have good interconnectivity with itself. And so I would just say, don't prevent yourself from finding someone because there isn't necessarily a direct list. Would you want to add to that, Skye or Allison?
I think that's a really good piece of advice. You know, I think there are a lot of therapists out there, and especially in the Seattle area, that do focus on chronic illness. I don't have a list off the top of my head or anything. But one thing that I would suggest, you know, besides finding a therapist that you do click with, because a lot of times just being able to speak openly and freely with your therapist, you know, removes a lot of those barriers. But another thing you could do is Psychology Today actually has a really great search feature, and you can filter out specifically chronic illness, or I don't know if they have a specific like IBD function or search feature there, but they might. So it's worth a try.
Yeah.
Psychology Today?
Yeah. And you can search by your insurance as well, which is really helpful.
Is that something people can find just by Googling Psychology Today, all one word, no spaces?
Yep, psychologytoday.com, I'm pretty sure.
I think
Okay.
it's .com, yeah.
All right, well, thank you for that concrete resource. And I also just wanted to pass along, somebody wrote, I love that, writing a letter even to ambiguous loss. I'm definitely going to do that. So not a question, but some gratitude for your useful advice today.
Thanks, Jody.
And with that, I'm going to go on to our next topic. So we'll shift to the third presentation. What is remission? Treat to target. And this is going to be Dr. Alina Wong. And Alina, do you want to unmute your mic and start us off with just a summary of what your topic concerns and what the key points of it were?
Yeah, thanks, James. So, you know, Crohn's and ulcerative colitis are chronic relapsing conditions. And because of that, they can result in a lot of complications, whether it be frequent use of steroids, hospitalizations, surgeries, stricturas, fistulas. And to help prevent those complications, we want to get our patients into remission. But one of the biggest questions is, what is remission? Is it just feeling better, getting your symptoms under control, your diarrhea, your abdominal pain, bloody stools? Do we want to get endoscopic remission? Do we want to get our labs to look better? Or lastly, you know, kind of the last frontier is, do we want histologic remission? And I think for many years, we followed symptoms. And we still definitely want to make sure that everybody feels better. But what we've learned is that symptoms alone aren't enough. That we want to get people into endoscopic remission as well. And around 2015 is when the STRIDE committee came out with guidelines about treat to target. And that's really about assessing the patient, assessing his disease, assessing his risk for progression and the risk for complications, picking a therapy to kind of match that risk, and then monitoring them intermittently with labs, endoscopy, whatever's needed to help, and reassessing to see if those targets have been met. And that's really to help prevent the long-term complications.
And can you define for us a bit what you mean by endoscopic remission and histologic remission? I don't think those are kind of common terms.
Yeah, thanks, James. So endoscopic remission, so, once we start a new therapy, we want to see if those original ulcers or inflammation in the GI tract has healed. So we take a look with our camera, whether it be an EGD or colonoscopy, or a camera, like a pill camera, to see if those original ulcers have healed. And our goal is to see if they've improved or gone away. And that would be endoscopic remission. Histologic remission, which has been talked about recently, is not only do we want to see that the ulcers have healed based on endoscopy, but when we take biopsies, that on those biopsies that there's no evidence of inflammation.
So under the microscope.
Yeah.
Pretty high resolution as a standard. Well, some questions came into you before the conference, so I'm going to read from my email here. Dr. Wong talks about the goal of preventing long-term complications, but we rarely hear about what can be done for those of us who went undiagnosed for years and already have strictures and internal fistulas. Even when our disease responds well to modern therapies and inflammation is greatly reduced, we still suffer from, quote, the legacy of our anatomy, end quote. Great term there. Yeah. Are there any new treatment options short of surgery for cases like this?
Yeah, and that's a really great point, that even if you have healing of the inflammation, then endoscopically it looks healed, you can still have a lot of long-term effects from it, such as the strictures, and then the dysmotility and the symptoms that come from having those strictures and different anatomy. So, the question is, what can you do about it? And like you said, there's the option, depending on the stricture and the symptoms, obstructive symptoms that you're having, there's the option of surgery. Endoscopically, we can often dilate, so do balloon dilation to open up strictures. Cleveland Clinic has been talking about doing stricturotomies, so actually cutting the stricture from the inside using an endoscopic tool. That's only done there and by a highly specialized group of people. But that's definitely an area that people are looking into, like what else can we do but surgery to help you feel better and kind of help with the long-term complications that our medications aren't going to treat anymore.
Another question I was emailed, and I'll give you a little background. I mean, there's a bit of background before the actual question. So this writer said, I found Dr. Wong's presentation on what is remission very interesting and helpful. I would just ask for some clarification on what one can know about how relief from symptoms relates to remission. In my experience, throughout my lifetime, I've gone through several years of seemingly good health between serious, relatively short-lived flare-ups that have required surgery. Can that mean that the disease, Crohn's in my case, has been insidiously working in the background to develop scarring and eventual stenosis while I was generally unaware? Does that mean that treatment of some sort is wise even during periods when one is feeling relatively well?
Yeah, so that's a really great question. Especially with Crohn's disease, we've learned that symptoms really don't correlate with disease activity. Up to, in one of our original trials, the SONIC trial, up to 50% of people who felt well actually still had disease activity. And then, in kind of correlation with that, you can still have symptoms and not necessarily have disease activity. So you can go both ways. And that's just because of, in Crohn's, it really, especially if you have small bowel Crohn's disease, it doesn't correlate as easily with symptoms. So like with ulcerative colitis, if it's in the rectum, you're gonna have bloody diarrhea, and that correlates much better. But with Crohn's, it's so high up, and because it can cause strictures and cause things that can change your symptoms, it's really hard to just follow symptoms. So because of that, and hence like the reason for these STRIDE guidelines and treat to target, we want to make sure that if you're feeling well, that's great. And that's our, number one, we want to get you feeling better. But number two, I want to make sure that you don't still have active disease in your small bowel or colon that I would need to alter or change therapy for. And we can do that by either looking at it endoscopically or using a pill camera or looking at labs to make sure that your disease is really under control to help prevent those complications in the future.
So, so somebody asked, if a patient is happy and stable with a line of treatment, should he or she push to achieve histologic remission? So I think more generally, what is the threshold for actually upsetting the apple cart and trying to mess with success if you feel fine, but you can still see that there's some active inflammation?
Yeah, and that's really one of the main questions we as gastroenterologists have to kind of struggle with is that, when do we call it, when is good good? Sometimes we have a certain number of medications at this point, right? We don't have indefinite number of medications and we don't want to run through them all. So at some point we have to say good enough is good enough. And the question is when is good enough? And I think a lot of it is an individualized conversation with the patient, looking at the risk factors, what kind of disease process they've had thus far. If they've had very severe disease and I've gone through most of my medications, but this last one has gotten them, partway into remission, then maybe at that point that's good enough. But in general, we try to, look for endoscopic improvement, histologic improvement. That's definitely, I think, the next frontier, and maybe in the next X number of years, that will be something that we strive for. But at this point, we don't even know if we can get everybody into histologic remission. And what is histologic remission? Is it getting rid of any inflammatory cells? Is it getting rid of the architectural distortion? We really don't know at this point in time.
So somebody had an interesting question about the overlap between IBS and IBD. This writer says, I've had IBS all my life. It's hard to distinguish, I presume, from IBD. They say, I take a Lomotil every morning, so my diarrhea is under control, but the colonoscopy showed active disease, which actually sounds, kind of like what we've been talking about. What do you do if you feel fine, but there's still active inflammation? And if it's requiring Lomotil to control that, I can predict what your answer is going to be. But I'd like to turn this question on its head and say, what about the reverse, where you are still symptomatic, but your endoscopy actually looks pretty good?
Yeah, and as I mentioned previously, I think around 20% of patients can still have symptoms despite having no active inflammation on endoscopy. And that really has to do with having, a lifelong history of inflammatory bowel disease or having IBS on top of it. You can still have symptoms due to motility, due to SIBO, due to past surgeries that cause symptoms. And I think once you've done a thorough assessment to make sure there's no evidence of active inflammation, then it's really about treating those other symptoms. And there's still a lot we can do. For example, if you've had a stricture, you've had surgery, you can talk about treatment for SIBO. If you've had resections for bile salt diarrhea, there's still many things we can do to get you to feel better. But there's definitely, it's important to help distinguish if there's active inflammation or if there isn't.
And is inflammation always IBD?
That's a great point too. No, active inflammation is not always IBD, right? We have to make sure that you don't have infections like Elisa was talking about. We have to make sure there's no COVID, that there's nothing else going on as well. C. diff, CMV, inflammation is not always IBD.
Although I will point out that COVID has not actually been found to be a gastrointestinal pathogen, despite the fact that the ACE2 receptor is expressed by the small bowel brush border more than anywhere else in the body. At present, there is zero evidence that viable virus exists in the human GI tract. So probably the bits of virus that we're picking up in stool are just from your respiratory secretions going down your esophagus and through your stomach. But yes, there are other infections that are really important in the GI tract. But I don't want to scare anyone to say that the gut is where COVID is infecting them. Okay, well, we're actually past 11 o'clock. I'm sorry that I was not very strict about enforcing the clock earlier on. Let me just check and make sure. I think there might have been, nope, I got all the emailed questions taken care of for this half of the talk. So if anybody has any more questions, please raise your hand, unmute your mic. Last chance to ask anything of our speakers. Otherwise, Jody, I think we're going to be taking a break here, aren't we?
Yeah, I think we'll just take about 5 minutes, get up, move around, and we'll kind of shift to our next panel. I do want to just take a moment and thank all of you so much who have sent questions today. I think it's really made the discussion more rich, and it's really improved the quality of our overall education program. So keep them coming, and we'll see you back here at 11:10. Thank you.
And thank you all of our speakers for not just granting us your morning, but also for creating this durable resource on our website that will serve us for many months to come.
Yeah, I think that's super valuable. We'll be really trying to push this out through our CMAC and whatnot, so that, you know, as the library builds, if there's a particular issue that a patient is having, we'll be able to say, you know, there's this video that was created on this topic, you know, check it out in your free time from your living room. So really appreciate your effort behind helping us get that started. Thank you, all of you presenters, very, very much.
Thank you for having us.
Thank you.
All right.
Thank you.
And Jody and I will be back here in 5 minutes.
Yes.
All right, I'm going to go grab something to drink. Oh, I see somebody had a clarification of terminology. What is MAC? CMAC. CMAC actually is just shorthand for the Chapter Medical Advisory Committee. This is just terminology the Crohn's and Colitis Foundation refers to the local physicians in our area who volunteer their time to help out with many aspects of the Crohn's and Colitis Foundation's mission, such as offering to organize and give these talks that they recorded over the past couple of weeks and have posted to our site and are now doing this Q&A this morning. So that's the Chapter Medical Advisory Committee, is just a large group of physicians, including some of those who came on today to talk. It's a little bit different from there's a board for the Northwest chapter as well. Some members of the Chapter Medical Advisory Committee are on the board, but most are not. So there's just subdivisions within the organization. But sorry, we shouldn't use shorthand like that. It's just bad habit.
Yes, sorry about that.
Well, it's been 5 minutes, so if we're going to be strict about this, I suppose we should charge ahead here. So do you want me to keep going, Jody, or do you have anything you wanted to say with the second half?
I just wanted to take a quick minute, I guess, to thank again our sponsors for today. I'll show those slides again, but we have the Seattle Children's Hospital, Swedish Gastroenterology, Washington Gastroenterology, Premera Blue Cross, Takeda, and Janssen. Some of their representatives have joined us, and we are just really incredibly grateful for their support as well.
Okay, so now we're going to go on to talk about the last 3 topics for today. And these topics are transitioning from pediatric to adult care, IBD and sexuality, and then IBD in physical activity. And so joining us to present these talks, for the first subject, we have actually a tag team between Dr. Jonah Essers, who's a pediatric gastroenterologist at the Swedish IBD Center, where he's particularly proud to be part of the very successful transition program where older children transition to an adult gastroenterologist for the next phase of their life. And he's been a longtime member of our Northwest Chapter Medical Advisory Committee here in Washington and a volunteer at our Camp Oasis for children with inflammatory bowel disease. And he's going to be tag teaming with his colleague, Dr. Karlee Ausk, also at Swedish. She's the Associate Director and Lead MD for Swedish's Inflammatory Bowel Disease Center. She's a regular contributor to the Crohn's and Colitis Foundation and currently is the chair of our Northwest Chapter Medical Advisory Committee. So glad we defined that term here in Washington. She's skilled at guiding patients in making healthcare decisions based on the best available evidence and tailored to their individual story. So with that, let's see, where's Jonah? Are you doing it solo today? Did I misspeak, Karlee?
Well, not that I was told. So I don't know where Jonah is. So I think I can either go ahead or we could move to one of the other speakers and come back and see if Jonah joins us by the end. I'm open to either.
Do you have him on your speed dial?
Yeah, I can text him.
Okay. In that case, why don't we do this a little out of order here? We'll jump ahead and put a more adult topic ahead of the more pediatric topic and talk about IBD and sexuality, a topic that is often on many patients' minds and something that we've historically been a little gun shy about discussing at our public meetings, but we thought that this particular avenue of providing an online conference may actually open this up a bit more and make it anonymous enough that people are willing to speak up and ask questions that we never normally get much of a chance to address. And so Dr. Mukta Krane bravely agreed to take on this topic that is where angels fear to tread. She is a colorectal surgeon working primarily at the University of Washington Medical Center in Seattle, specializing in inflammatory bowel disease and colorectal cancer. She's a longtime member of the Northwest Chapter Medical Advisory Committee here in Washington. And as a surgeon, deals a lot with many of the body image issues that come up in inflammatory bowel disease and really are often very central to the question of sexuality and inflammatory bowel disease. So Mukta, if you'd like to unmute your mic and just sort of summarize the key points from your talk, we will start taking questions concerning this important topic.
Sure, thank you. And thanks for everybody who's spending their Sunday with us and those that are going to be listening to the recording. So as James mentioned, this is a topic that I think is often not discussed, which I think is actually one of the major problems and barriers to care for sexual health issues. I am a surgeon. My research is predominantly in functional outcomes and quality of life after surgery. And so this is particularly important to me, both in the inflammatory bowel disease and colorectal cancer standpoint. I think that, you know, what I tried to stress in the talk was that there are a number of factors that affect sexual health, and sexual health is not just the absence of dysfunction or disease, but incorporates a lot of different domains, including comfort, including body image, including physical, mental, and social domains. And IBD has a way of affecting kind of numerous arenas. I think that this is a topic that a lot of patients have, in surveys that we've seen, have stated that they wish they did talk to their physicians about, or their healthcare providers about more. I think that they often question how to do that. I know from a surgical standpoint, usually I spend so much time talking to patients about the operation itself and the risks of the operation and the potential complications, that a lot of times we sort of only briefly get to discuss functional outcomes and quality of life, which is really probably should take up more of the conversation, or most of the conversation, because it is kind of what the long-term picture looks like. Sexual health can be affected by the disease itself. It can be affected somewhat by the medications, depending on which medications we're talking about. And of course, by surgery, both from a body image standpoint and anatomic changes that happen with surgery itself. And I also briefly talked about fertility, because I know that that comes up a lot. And while it is a bit distinct from sexual health, it is wrapped up in sexuality. And I think that what I tried to stress in the presentation was that there are a number of factors that can affect fertility. Most of them are actually sort of byproducts of IBD. So it turns out that fatigue, depression, anxiety potentially have a greater effect on fertility, and because of sexual desire and the act of sexual intercourse, more than necessarily the disease process itself. Surgery is a little bit different in that there are anatomic changes that can happen with surgery that certainly can affect fertility. But interestingly, in most of the data we saw, fertility did not dramatically change with treatment, and in fact, in some aspects, actually improved after treatment of IBD. I think that's probably it in a nutshell. I'm happy to go into obviously any sort of greater details depending on people's both questions and areas of conversation.
Well, Jody had passed me a few questions that had come up. First of these is, because this is such a difficult and sensitive topic to discuss with a healthcare provider, do you have any advice on how to get the conversation started?
Yeah, so I think it's so kind of ironic in some ways, because when you talk to your provider about IBD, you often are going into pretty significant detail about your bowel function. And I think most of us would in general feel uncomfortable with that topic as well, but we seem to be able to broach it pretty well when we're talking about IBD. I think sexual health and sexuality has been kind of this taboo topic, and it really shouldn't be. I think that you should think of it in a similar way as you do your bowel function. What I always recommend to patients, particularly because this can be uncomfortable, is that I think it's really helpful to come up with a list of questions. And I ask patients before they see me to write down questions that they may have. And then oftentimes I'll actually ask them to hand me that list, or hand that list to my MA when they're being roomed. So I have an idea of when I am seeing a patient what are some of their concerns to ensure that I do talk about those during the conversation. I think if you do that and you can write it down, it's a little bit easier, and then the onus is on the provider to then bring up the topic. I think it also creates a space for the provider to feel comfortable. One of the things that I discussed is, interestingly enough, most of the studies show that patients actually feel really comfortable talking to their providers about sexual health. It's providers that seem to be less comfortable. And so I think if you write it down and you ask it, then I know I'll look at it and think, great, I'm happy to have a way to talk about this. And the patient does want me to address this, both the knowns and unknowns. So I find that to be the easiest. In terms of providers, one thing that I've started doing is actually with every patient, we send a number of forms asking about your past medical history, your past surgical history, but very rarely do we give you a form when you are a new patient or coming in for a visit to tell us how you're doing in terms of quality of life, which is a measure that we should be looking at. So while we will ask, what your allergies are and what medications you're taking, I think regularly we should also ask, how are things going in multiple quality of life domains, and what are your concerns, and how can you help address them? So I've started adding that, and would advocate for any of the providers on here that has been very helpful in understanding what my patients want to know about.
That's actually really interesting. There is a tool we use in clinic called the SIBDQ, which asks a variety of different questions about quality of life. Not one of them concerns sexuality, and it is difficult to say that sexuality is not a central function of the human experience. And so that's an interesting observation that you've tried to rectify. Another question specific to you as a surgeon is that since surgery can have an impact on sexual function and fertility, are there strategies to decrease the impact of surgery on these functions?
So there are. So it's interesting because the surgical question is a bit of a mixed bag. So surgery on some fronts can worsen sexual function. There are actually some studies to show that sexual function can be improved with surgery. And so the absence of symptoms or a disease, which is hopefully what we can accomplish with surgery, may actually increase sexual health on a number of domains. So it's not always a bad thing. Sometimes surgery can actually help. Where we see surgery probably have the greatest detriment to sexual function and sexual health is when we're doing operations at the rectum. And the reason is because there are a whole bunch of nerves that sit right by the rectum, which are important in sexual function. And fertility as well. And so we can anatomically affect those. It's relatively rare that they are permanently injured with inflammatory bowel disease surgery, but they can be strained and they can become scarred. And so there are a few strategies. The first is, we are doing more and more minimally invasive surgery. And what we're seeing with that, and that's laparoscopic surgery with a camera, or robotic surgery, which is still with a camera, but using robotic instruments. And what we're seeing is that there is a lot less scarring. There's a lot less tissue handling. The incisions are much smaller. We tend to be a lot more delicate in the operation when we're using these instruments. Our view is better, so we can often see the structures that we need to and keep them out of harm's way. So I think the first thing we hope to see is a reduction in either injury or straining of the nerves and other structures like the fallopian tubes, the ovaries that are important for fertility, using minimally invasive surgery. The other thing is the timing of surgery. So in a number of procedures, probably what we do most often with inflammatory bowel disease that involves the rectum is removing the colon and rectum. And we do this for ulcerative colitis. We do this for Crohn's colitis. And often these procedures can be staged. So we can do the colon portion. I've had a number of patients that have come to see me, and I talk to them about things like fertility when we are talking about the surgeries, and they are interested in having of becoming pregnant in the next year or two. Often what we'll talk about is then doing the colon operation, but waiting to do the rectal portion. So they'll have an endoleostomy, they'll get pregnant, they'll have their first child, and then we'll go on and do the second operation, which may be either removal of the rectum or removal of the rectum and creation of the pouch. And what we know is that, thankfully, we are not affecting the function of the ovaries in terms of fertility. So people can still get pregnant, but we can cause scarring of the fallopian tubes, particularly again with the rectal dissection. So I think both the type of surgery we do, the way in which we do it, but also the timing of surgery. So if this is something that's particularly important to you, it should be discussed with your provider, because there may be things that we can do to both improve sexual function, improve your chances of fertility.
And a third question, you had mentioned in your talk the benefit of physical therapy. Can you elaborate on what that means and discuss a bit more how physical therapy can accommodate some of the problems that come up in inflammatory bowel disease or IBD surgery?
Yes, absolutely. That's a great question. So one thing that we often see is that people describe that they have pain. They have pain with intercourse, and that prevents them from intercourse. One of the reasons that happens is that actually there's kind of this network of muscles, the pelvic floor muscles, that are important not only for bowel function, but for sexual function as well. And with inflammation and scarring of these muscles, it can not only affect the nerves that run through the muscles, but can also affect the genitalia, can affect sexual pleasure. And so what we found is that with physical therapy, both before and after surgery, or in the absence of surgery, there can be treatment for some of that scar and some of that inflammation, making the practice of sexual intercourse in particularly more pleasant. The other thing is, one thing that we found is one of the main reasons why people are concerned or have fear, which is one of the issues with sexual desire and sexual function, is this fear of something happening. And most notably, what we'll see is a fear of incontinence, either urinary or fecal incontinence. And so we know also with pelvic floor physical therapy, we can often decrease the risk of that. And I think that that's often is one of the major barriers to sexual function.
Does sexual function include emotions and attitude?
So I think sexual health does, for sure. And it's interesting because the WHO definition of sexual health takes into account social, emotional, physical, spiritual domains, and looks not only at sexual function, which I think of as more anatomic, but also relationships. And one thing that we've seen time and time again is that when asked specifically, not just about function, but about things like sexual health, that patients often report that their disease has significant effects on their relationships, and particularly their sexual relationships. So I think sexual health and sexuality encompasses much more than just function. I think in medicine, we often tend to focus on the function, but there's probably a lot more that we can do in the other domains as well.
Somebody had an interesting question, sort of ties back to Elisa Boden's topic. Can you address the issue of sex, kissing, etc. in terms of COVID-19? I'm not working, but my spouse is going into work in the evening when most are gone, but still there is some risk. We are nervous about getting this close.
So, I've heard this from a lot of patients in the IBD setting as well as the transplant setting. I think with any close contact, there is going to be some risk. I don't know of any additional risk with sexual intercourse. With kissing, I think it's a little bit different. I have talked to a few patients who've decided that they just are not going to participate in any type of physical contact until they feel safer, and they've kind of partitioned themselves and they stay 6 feet apart. I think ultimately it is what you are comfortable with. Can there be a spread of COVID-19? Again, I would think with kissing, there would be an increased risk, but I don't know that we have sort of true data. I think it would be hard to parse out because the act of that is you're going to have really close physical contact with somebody, which we also know is risk. is at risk.
Although isn't COVID predominantly becoming known as inhaled vector? I mean,
Yes.
it seems
Yes.
like people breathing the same air are the ones who transmit
Correct.
the disease to each other.
Correct.
In which case, the case in point for this question is two people living in the same household. Do you think that in this setting, kissing and having more intimate contact would actually increase the risk of COVID above and beyond simply breathing the air in the same house all day, every day?
Yeah, I think that's probably unlikely. I think you're right. I think we're seeing that this is more an inhalation, and that touch is probably less concerning. So no, I think that if you're in the same household, I think there's a difference between whether you are, socially isolating and socially distancing in your own household, which people are doing. But I don't think that sexual intercourse, at least I have not read anything that it increases the risk beyond being in the same household with somebody in close contact.
Thank you for that clarification. And this isn't a question that was phoned in, but I think it's a key question that comes up an awful lot in my clinic. One of the biggest issues to sexuality that people encounter and are afraid of is body image, particularly with an ostomy. And your clinic deals a lot more with ostomies and than a medicine clinic does. So is there any advice or any tips and tricks that your ostomy nurses talk to people about in terms of ostomies and their sexuality and their body image?
Yeah, so I think that this is sort of a key component from a surgical standpoint. I think that there is also a lot more now in the media of people feeling more comfortable with their bodies and having bodies which include an ostomy. One thing that we have done is we've set up actually a number of patients of all different ages, different genders. And we actually continue to try to put this network together where a new patient who is thinking about an ostomy or may need an ostomy can have. Sorry about that. Go out, Mike. May talk to other patients about what their experience is like. Again, I think a lot of it is based on sort of this unknown or fear, and being able to talk to other patients that have been in a similar situation, I think is incredibly helpful. I also think that there are a lot more sort of appliances and devices. So there are appliances that can be put over the stoma so that there isn't drainage during the course of sexual intercourse. There are different lingerie that can be used or different clothing types that can be used in order to I don't want to say hide, but maybe not show aspects of the stoma that patients are concerned about. So I do think that this is an area where actually there is a lot available to patients. And I know that this is, for our stoma nurses, something that they tend to talk about a great deal with patients. But again, I find that one of the most helpful aspects is being able to talk to other patients who've experienced it and knowing what some of the pitfalls are, and frankly, knowing that they still have healthy sexual lives.
Yeah, it's tough to know what you don't know.
Yes. And I think that goes with a stoma in almost all settings. I know I have one patient who often will talk to patients and has sort of volunteered to be a resource. And one thing that he generally will tell patients was that, he had significant incontinence prior to surgery. And so he said that the trade-off, his sexual function improved significantly because he was able to manage the stoma. And so this fear of unknown of the incontinence, which he actually couldn't manage, and he found much more embarrassing in the long run. And so that's something that he'll often talk to the patients about that experience similar things.
All right. Well, thank you for exploring this sensitive topic, Mukta, and I'm sure that your recording will be quite widely distributed in the near future. It looks like Jonah has joined us, so I'm going to once again introduce Dr. Jonah Essers and Karlee Ausk from Swedish to talk about the transition from pediatric to adult care. And so without further ado, Jonah, do you want to summarize what was in the presentation that you graciously recorded? And maybe the two of you together can kind of tag team just discussing what the key points were to come out of that.
Yeah, so thank you all for having me here, and thanks for spending part of your Sunday with us. And really the summary is that pediatric gastroenterology practices look very different from adult gastroenterology practices. It is a really great way for a child with a complex medical problem to learn about their disease, to have sort of a lot of wiggle room to explore how to access healthcare. We often spend a lot of time grooming families to eventually let their child fly the nest and eventually become an adult. But there's really a lot of work to do to get them to that point. And historically, pediatricians have not prepared patients, specifically inflammatory bowel disease patients. Historically, we have not done our part to get these patients ready for the way an adult practice runs. And there's now a large body of literature to suggest that there are action items that we have not, as a community, lived up to. So really the message is that transition is a process. It's not a moment in time. It is a process that happens over many years. And it starts as soon as a patient is in an age-appropriate position to start talking about transition, which is really around age 11 or 12, which is the beginning of what we refer to as emerging adulthood, believe it or not. And that process is a longitudinal process with many iterations. And it might start with something as simple as starting to get to know the names of your medications, the dosages of your medications, to start to discuss how does one articulate what your needs are, what's going on with you today, what are your symptoms, and how can we help you? And eventually in the later stage of that, it's around coming to appointments alone. It's about calling your own provider to make an appointment, troubleshooting problems and discussing signs and symptoms with your doctor without your parent present. And really you get to a point eventually that when we do the handoff, that it's a seamless, effortless, and painless transition.
Yeah, I think Jonah said that very well. And I think the key is really just that as parents of a child with a chronic medical condition, it's very easy for us to take control of the condition and the medications and the appointments. But the key first is really education of the patient and the emerging adult, and just helping them gradually take their own independence and responsibility. And then the second key is finding an adult provider that you feel as comfortable in your relationship with as you did with your pediatric provider, because your pediatric provider has been through so many trials and tribulations with you. And so as you move, you don't have to just settle with the first person that you see. You want to find someone who matches your personality and who you can really feel comfortable with talking about things like sexuality or whatever you feel like you need to talk about with them with.
So there were some questions that were sent in ahead of time. And so I'm going to read something here. Somebody wrote in that they said, I was diagnosed with Crohn's disease in 1964 when I was 10 years old. Before endoscopes, when imaging consisted of barium x-rays and castor oil prep, and the only effective treatment we were aware of was prednisone. I don't know if there is such a thing as a pediatric gastroenterologist in those days, but I found the presentations by Drs. Essers and Ausk to be about transitioning care from pediatric to adult care fascinating. I have no regrets about my journey in healthcare through adolescence to adulthood, but at the time, I thought I was alone in my experience. An organization like the Crohn's and Colitis Foundation would have been very helpful in navigating that difficult time. I have two questions. Number one, actually, it looks like there are 4 questions. No, 5 questions. So what is the age group distribution of those with IBD? And the sort of subsets of this is there a large percentage of children, and how early in childhood can it appear? Those are all kind of related questions. So that sounds more like your bailiwick, Jonah?
Well, I think, first of all, I couldn't have commented any better than you did in terms of how far the field has come. You know, as chronic diseases go, 2020 is the year to get a disease like inflammatory bowel disease if you're going to have one. And the amount of support and the taking the body of information that we've learned over the last 50 years, we are clearly in an inflection point in terms of taking care of certainly kids and also adults, both in terms of the way we think about the disease, the way we act as a community to learn from our mistakes, and also in terms of the drug pipeline. In terms of inflammatory bowel disease, one of the reasons why transition, I think, if you read any body of literature on transition of inflammatory bowel disease, the introductory paragraphs always start the same, which is that being a child with inflammatory bowel disease is worse than being an adult with inflammatory bowel disease. The presentation is more aggressive. It covers more area of bowel and is more recalcitrant to medications and interferes more permanently with bodily function. And so that's one of the compelling reasons to have a transition program, is that these patients that are coming to the adult gastroenterologist are almost by definition going to have had a sicker, more complex journey. Okay. So to answer one of your questions, kids are worse than adults in general, if you were to generalize. The youngest, now that you think you say, how young can you be? There are patients that are diagnosed as early, technically as early as under 12 months of age. These are incredibly rare. These are usually what we refer to as monogenic or Mendelian disorders, which is to say it's like one bad gene that has caused such a mess that these patients are presenting almost after they leave the womb. They're very rare, extremely rare. My personal youngest patient was age 2 at diagnosis. Most pediatric gastroenterologists have several outlying patients that were diagnosed around age 2 to 4. But I would say for most of us, the first big peak or spike in terms of diagnosis for Crohn's and colitis would be around middle school to early high school. And that's what I would say the vast majority of pediatric patients. And then if you look overall, pediatric patients or pediatric onset IBD is probably felt to encompass about 20% of all cases in terms of at diagnosis. How old were you at diagnosis? About 20% of patients were diagnosed in the pediatric population. We can split hairs and talk about what is considered a child or a pediatric patient. It's probably beyond the scope of this lecture. But certainly it is a decent chunk of patients. And up until very recently, that risk, the incidence or the rate at which people are developing this disease had been increasing for decades and decades and decades. And so certainly I came of age as a pediatric gastroenterologist at a time where they seem to be, quote unquote, coming out of the woodworks. We have seen some stability in terms of the incidence over the last, I would say, 5 to 10 years. And it's not to say that the incidence of pediatric IBD is going down, but it's certainly started to plateau. And there's a lot of reasons or hypotheses why that might be.
And Karlee, at the other end of the spectrum, this question said, what percentage of patients are in my age group, 65 and older? And I would differentiate that both into what people are currently in that age range living with IBD they've had for a long time, such as the author, versus what percentage of people are newly diagnosed later in life with new onset inflammatory bowel disease. Because I think that the marked increase in screening colonoscopy may have created a detection bias that has sort of changed the landscape in terms of new diagnoses of inflammatory bowel disease.
Yeah, we do see just sort of in the onset first of just diagnosis, there tends to be 2 peaks of age range at diagnosis. And the first is sort of within the teens to early 20s. And that's the largest peak of the age that people are diagnosed. But then there's also a second peak kind of around the 6th decade of life, where you're also seeing more diagnoses. And whether that's because of new onset, or because those are people are getting their screening colonoscopies done and found to have less symptomatic or even asymptomatic disease. I have had people as late as in their 80s that have been newly diagnosed. And so it can certainly be diagnosed at any of those age range. Then the second category, though, is people who have lived years or decades of their life dealing with inflammatory bowel disease. And so that's a very different population, because they are ones who have had, again, years and decades to build up cell changes or scar tissue that's going to affect how well they respond to medications, and also affect their risk of complications like strictures or colon cancer. And so that population does look different.
Well, I beat your record, Karlee. I made a new diagnosis in a 92-year-old once.
Wow.
So actually, speaking of screening colonoscopy, another question related to this was, the author was surprised to hear that, quote, malignancy surveillance, end quote, was a focus of treatment, diagnosis, and care, and how much more prevalent is bowel cancer in IBD patients than the general population? I'm not sure which topic really addressed this. It's not that specific, except that it does reflect a shift in the treatment paradigm between pediatric and adult onset. And so that may be something that you want to speak about, how our goals of what we're trying to accomplish shift between the pediatric population and the adult population.
Yeah, I think often with the pediatric population, their focus is on disease control so that the patient can go through normal development, both physical and neurological development through their growth, and bone health and vitamin nutritional deficiencies. And as they come to the adult clinic, we start to think about someone who's had chronic inflammation over many years and what complications that might lead to. So specifically, colon cancer in this question is at an increased risk if someone's had chronic inflammation in their colon. And that risk doesn't start to increase until you've had colitis for at least 8 years. And so often that's not a time frame that the pediatric GI providers are dealing with, but a time frame that as adult providers, we start to think about, we should be doing colon cancer screening if you've had ulcerative colitis or Crohn's in your colon for longer than 8 years. And then there's recommendations that you have more frequent colonoscopy at that point. So the risk of colon cancer is not dramatically increased for these groups, but increased enough that they need to go through regular surveillance, because we may be able to find precancerous changes and remove them with a colonoscopy to then prevent colon cancer from forming.
One of the things that I have found in my experience in working so closely with Dr. Ausk, in terms of, you know, I have a lot of patients that I transitioned to her specifically. And one of the things that's so interesting is, and I will go to this first visit with my, with my patient to Dr. Ausk's office and to sort of pass the torch. And one of the first things that comes out of a lot of those visits is, looks like we should do a colonoscopy and see where things are at. And that's something that is, hopefully, my patients have come to expect that might happen, but it really reflects just the different philosophy in terms of how we practice with a quote unquote child and with a quote unquote adult. I'm always looking for reasons not to scope a patient. And obviously I'm trying to practice to the state-of-the-art way, which does involve, doing colonoscopies periodically to see where we're at, especially post-surgery. But I am often using like clinical and biochemical remission. Do you feel good, and does your blood work look okay? Do your stool studies look good, and are you growing? As a way to say, hey, I think this is probably a good place to hold. Whereas in the adult population, we're often saying, well, we should probably prove that you're in remission endoscopically or with your biopsies, and also we should probably do a malignancy check. And so it's just this philosophy of, when I'm working with a 10-year-old, they've got their whole life to have colonoscopies. So I'm usually trying to say, hey, maybe we don't need one this time. And then after the transition, usually they've had disease long enough that the surveillance process does begin. So it really is part of that transition process, really is trying to have families understand that the ball game is kind of changing a little bit once you transition. Maybe
we should have had you tag team with Dr. Alina Wong's talk too. So she was talking about the deep remission, endoscopic and even microscopic tissue remission. And it sounds like that is an unrealistic goal in pediatric GI just because of the logistical issues with performing such invasive procedures on children.
It's realistic, actually, and it really depends on how a family is processing information. So if they say, look, we've read a lot about mucosal remission and we want our child to be in mucosal remission, we say, great, let's have that be the target. But for some families, it's, hey, we need our child to not be in the hospital all the time. We don't want to do bowel preps every 2 years, and so that's what it is, a negotiable thing as long as we're reaching a target that is universally felt to be acceptable. And so there's the way I like to refer to it is there's the academic conversation and then there's the practical conversation. And in pediatrics, there is a chasm between those two often.
And we do tend to think of colon cancer prevention as being uniquely an adult medicine issue. Are there any exceptions to that in pediatrics where you do actually need to start colorectal cancer screening surveillance earlier?
Absolutely, and it's exactly what Dr. Ausk said, is that if I have a patient who is unfortunate enough to be diagnosed with colitis in particular at a young age, they will get 8 years out and still squarely be a pediatric patient. So I'm thinking the 8-year-old I just made a diagnosis this week with ulcerative colitis, he will get his cancer screening at 16, a sophomore year of high school. Historically, pediatricians, this is not in our wheelhouse. We don't understand, we don't think about dysplasia and some of the way that the lining of the gut changes over time. So once we start to have these kids that are going through cancer screening, if we find something that doesn't look so hot, you will find most pediatric GIs reaching out early to adult GI to say, hey, we might need to speed up this transition process. And Dr. Ausk, I don't think we have any patients for which that has happened, fortunately, because the rate does still tick up slowly. But yes, the correct way to do this is about 8 years after diagnosis, especially for the colitis patients. The Crohn's patients, especially with small intestinal disease, that's debatable.
What about sclerosing cholangitis? And for those of you who are not gastroenterologists, this is a liver condition that is often associated with colitis. And it, for some reason, markedly increases the risk of colon cancer. So we usually don't wait 8 years to start screening. But I actually have no idea if kids even get sclerosing cholangitis.
They sure do. They do get sclerosing cholangitis. They get other liver things like autoimmune hepatitis or overlap syndrome. So you can have, but specifically sclerosing cholangitis, the answer is yes. And like in adults, the colitis, the inflammation in the gut is actually quite mild. And yes, these patients do undergo expedited surveillance. The pediatric literature is actually still really mixed in terms of when to start that. And the main reason for that is that even though their risk for cancer is significantly higher than age-matched peers, it's still, the absolute number is still really low. And so the debate is, do we start at 8 years? Do we start at 4 years? And there really isn't any consensus. In my practice, for the 5 or 6 patients with PSC that I currently manage, I'm aiming for about 8 years because I have not found a compelling reason to do it sooner.
Yeah, 100 times nothing is still nothing.
Correct, that's right.
All right. Well, let's see. There is a question. I thought that biopsies in a colonoscopy are to find cancerous cells. Do I understand that they are also to find inflammatory cells? In a colonoscopy, does the scope go up far enough to discover inflammatory cells with a biopsy if Crohn's is primarily in the small intestine, or do you need an upper endoscopy? Is the capsule endoscopy the only way to see the whole length of the tract?
Yeah, so yeah, since I'm the one that does more of it. So yes, they are also to check for inflammation. So in this era that Dr. Wong talked about of looking for histologic remission, taking biopsies can give you a sense of how somebody's ulcerative colitis or Crohn's might be doing. Whereas if you see no active inflammation, they're in a histologic remission. But if you see active inflammation, then that may or may not change your discussion of their medicines. So Crohn's disease, we can with a colonoscopy look at the last several inches of the small intestine. And that is also the most common area that of the small intestine that Crohn's affects. So if that's where your Crohn's is, a colonoscopy would also be able to check on it. Now, your small intestine is very long, and we certainly can't easily get through it with a scope, definitely not with a regular colonoscopy. And so if your Crohn's disease is in a small intestine that's higher up than those last few inches, then a colonoscopy may not discover it. The options at that point would be the capsule endoscopy, which is a pill you swallow that travels through, or small intestine imaging. So most often we use called MR enterography or CT enterography, special CAT scans or MRIs that look at the entirety of the small intestine and give us a better idea about active inflammation and also scarring in the small intestine.
And this is actually, I mean, as long as we're on the topic of the pill camera, earlier on in the conversation, there was talk about, earlier on in the meeting this morning, there was talk about COVID-19 and telehealth and what can be done remotely to maintain social distancing during clinical care. And I made the point that, you know, you can't do a scope by remote control, but PillCam actually is a bit of an exception to that. Has there been any talk about increasing the use of the pill camera to look at small bowel Crohn's disease instead of colonoscopy purely for the purpose of social distancing?
I have not heard about any of that. You know, I do think you're still having to come in because you have to come in and swallow the pill, which the nurses administer to you. You have to bring back the monitoring device. And we also have to make sure that your small intestine Crohn's is safe to get the pill. In other words, you don't have a stricture that this pill is going to get caught on. And so sometimes that leads to extra testing before the capsule endoscopy. So I haven't heard of any talk about that. I think for those reasons.
Mm-hmm. So we still basically have to bring people in if we want to get any sort of visualization of the GI tract.
Yep.
Okay. Well, I think that's all the questions that I have for you guys. So at this point, I'm going to move on to our last topic.
Before you do, can I ask a question?
Oh, sorry.
Sorry,
Yeah.
I should have written it down. I have a question, you know, as a surgeon that I think may be pertinent to some of the families with this transition. The two is that with most of my patients, I'm an adult surgeon, so with most of my patients, I'm just making the informed decision or, you know, working with the patient in terms of consent. When a patient is transitioning from the pediatric setting to the adult setting, I guess one of my questions is, what should I be doing to facilitate that? So whereas it's probably been a family decision, you know, should I ensure that parents are still involved if the patient is now considered an adult, but they've historically made all of these decisions as a family? That's my first question. And my second question is, at a university, I see a lot of patients that have now had to transition not only to an adult practice or adult surgeon, but are in a different place in the country than their family. So now they're going to college. And I imagine that patients are making multiple transitions. So they're often asking me, should I have surgery closer to home with a surgeon there where I'd be with my family? Should I have it here? And so just in terms of the transition process as a surgeon, what can I do to help that? And how would you guys recommend answering that question?
Wow, that's a great question. I'm so glad you brought that up. I'll tell you in my experience. So first of all, is just a quick background. The pediatric GIs generally transition their patients kind of either at the end of high school or at the end of college. It just depends culturally where you practiced and where you train. I follow my kids all the way through college, unless they're taking the 5 or 6 year plan, and then I kick them out. And what I have found is the vast majority of my kids are making family decisions. And so when they are faced with a big decision, they are almost always looping in their parents. And maybe that's just the style of practice that I have bred with my patients. But what I have found is that you still really want to involve the parents for big decisions. And usually after somebody turns 18, generally what I start to do is I will say, would you like your parents to be a part of the conversation or not? So I always will start with the courtesy of speaking with my patient, but then, and obviously I know my patients pretty well, so I'll say, hey, why don't you loop in your mom or your dad up for this one so we can talk about it? And I give them permission to push back and say, nah, I can do this without them, but they generally do. I think the main reason for that is not because they're not cognitively capable of making a decision, but because they make a better decision when they involve their caregivers. The second part of your question, so I guess in summary, absolutely inviting them to bring the parents on board and letting them know that you will take that extra time for that, I think would be very valuable. The second part of that question around college and transition, boy, that's a really tough one. I have a kid at Brown, a kid at Penn, I have a kid in Washington, D.C., one in Michigan that are all my patients. And this is tricky because it's really, I am going above and beyond for these kids, to be perfectly frank. And it's my pleasure and duty and honor to do that. But it requires a lot of resources because they'll call you, East Coast time to have a discussion about something. And it really is hard to know where they should get a big surgery done. And so I don't have a rule of thumb for that. I really honestly don't. What I have all families do is I have their kid register with the Office of Disabilities at whatever university that they're at. That way, if they do decide that they want to come home for a bowel resection and they're going to be out for 6 weeks before going back to school, if they've registered with the school in advance, then they're able to either A, get their deposit back, B, have their grades be put on incomplete instead of a fail. The professors are much more likely to sort of say, look, we'll make a special plan for you. Go home, get your surgery, take care of yourself. We'll figure it out over the summer when you come back. And so encouraging families to make sure that they're a person of interest with the school will then allow these kids the opportunity to decide whether they want to fly home for a surgery or to be taken care of. For some kids, it's just not tenable. And if that's the case, then I usually often will make a clean break with them. If they're going to be getting high-level surgery and they need a high-level intensification across the country, generally I am doing a warm transfer. I will call personally a provider on the East Coast and say, look, he's all yours. It's time to take over and help this kid get better. But it really is hard to micromanage somebody from afar. That's what I found.
So in this era of COVID, where suddenly telehealth is a huge part of what we do, Jonah, are you finding that it's harder to make a clean break, or is it actually really nice that you can basically stay this much more involved from 3,000 miles away?
Honestly, I love it. I think it's just for me personally, one of my great joys is watching these emerging adults sort of, they've got, to be frank, they've got grown-up bodies, but not quite grown-up brains yet. And I love mentoring them through this period. It brings me a lot of joy. So it doesn't feel like work for me. It is a lot of hours to do that. And telehealth, I think, has only provided one more tool for us. It has not been, it has not hampered my ability to take care of patients. The caveat, though, is that I've been fortunate enough to have most of my college patients remain stable. For the occasional unstable patient, it has definitely been hard, and it's challenging for the parents. It's challenging for me. It's challenging for the kid, and it's challenging for the school.
All right. Well, thank you. So if there are any other questions, sorry, I didn't mean to cut you off, Mukta, but it is actually after 12. So I want to get on and introduce our final speaker of the day. This is Katrina Taylor, a researcher and professor at Eastern Washington University in Spokane. Katie has a PhD in exercise physiology and did a doctoral thesis on IBD and exercise. So she has a lot of passion about continuing research in inflammation and exercise, particularly related to inflammatory bowel disease. And part of this is because her undergrad mentor has IBD, and her mom has also an autoimmune disease, type 1 diabetes. Let's see, Katie, there you are. Yes, you're a video now. You were an icon a moment ago. So Katie, you're unmuted. So could you give us a summary of your presentation that you graciously recorded for us in the past several days?
Absolutely. Yeah, thank you for the invitation to join this great group of experts today on various topics around IBD. It's always really humbling to hear the real doctors talk about their experiences with working with people with IBD. So my presentation really looks at this idea of physical activity, and we interchange very commonly between physical activity and exercise. I personally will always default to physical activity. Exercise we often remember as the time that we were punished for talking in PE class and were made to run laps and those sorts of things. So physical activity it tends to have a little bit more positive emotional response. We don't see it as quite so demanding. But equally, they're both really beneficial. And over the since the 1950s, we've really had this concept that physical activity and exercise are beneficial to physical health. More recently, we've started to understand that it's also beneficial to mental health. The first research study really looked at physical activity in cardiovascular disease and morbidity and mortality. And from that, we saw that this concept that physical activity, or as it's been titled, exercise, is really medicine. And so when I embarked upon my PhD, I knew I wanted to do something around this idea. But there's a lot being done by a lot of amazing researchers in the world of type 2 diabetes, obesity, cardiovascular disease, and I can't compete with those. And from my experiences working with Dr. Lindsay Bottoms when she was my undergraduate mentor with Crohn's disease, I really wanted to embark on that idea. And there was a lot of research the year that I was looking for a thesis topic that looked at the gut microbiome, which is obviously an up and coming research topic, particularly in terms of physical activity and the role that exercise may play. And so what we have learned is that there is a really minimal amount of research around the idea of physical activity and inflammatory bowel disease. And for some good reasons, there's definitely some misconceptions that it actually may not be good for people with IBD. And I think I quashed those fairly well in the presentation, that that comes from the idea of people running 26.2 miles or doing these Ironman triathlons where they do experience significant bowel disruptions afterwards. We term them often runner's trots. And they do feel nauseous and they do have excessive diarrhea, but they have also run 26.2 miles or longer. And that has something to be said. The mechanism of hitting the ground multiple times does cause microtraumas in the GI tract, and so can lead to these gastrointestinal distress symptoms. And equally, we take in very high fructose level substances during these to maintain our endurance, to maintain our fuel supplies. And so that equally can create some significant GI distress as we shunt blood away from the GI tract during exercise to be able to go to the skeletal muscles to help them work. And so when we look at the idea of physical activity in IBD, we actually see that there's a real beneficial effect. The research has been fairly limited so far in looking at health-related quality of life using tools such as the IBDQ, which you mentioned that you use in your own facility, and as well as other measures. But we do find that people's health-related quality of life significantly benefits from engaging in some level of physical activity, and that can be as little as walking for 30 minutes a day, 3 days a week. And equally, we've also found that it can benefit someone's not only their physical quality of life, but their mental and social aspects as well, which is extremely important when dealing with a disease like inflammatory bowel disease, which we know has a whole cascade of effects. There has been some research, and this has been really limited into children's populations or pediatric populations, in looking at inflammation. And we are seeing that there is some beneficial effect of different types of physical activity on levels of inflammation, which makes sense when we look at it from kind of a general population perspective, where a lot of our research has been done over the last 10 years, seeing that physical activity has an anti-inflammatory effect in the human body due to interleukin-6 when released from the skeletal muscle. And for those of you who are familiar with your inflammatory markers and your cytokines, IL-6 is kind of a two-pronged fork in that can be inflammatory and anti-inflammatory. And so there is minimal research, but it is very promising right now. And that's what I find very exciting about this field. And I kind of pose that we have some future directions where we need to step out of the pediatric field a little bit. I think that's been a good base for initial research, but we also need to look at the role of physical activity on inflammation in adult populations as well as in children, because like our doctors have said, they can respond to it different, and they can be different, and it can present differently with disease history. And then we also need to know what type of exercise. And one of my personal passions is looking at the idea of resistance exercise. This is something that has been really looked at in cancer populations recently. There's been a huge uptick in research on physical activity in cancer, which I think is really important with the connection of colorectal cancer, which is affected by lifestyle factors such as physical inactivity. I'm really looking at the different types of exercise and how they may benefit quality of life and inflammation, including things like resistance training, because it's always almost seen as more enjoyable sometimes by certain individuals. They may not like engaging in cardio exercise, and it may have less of an effect on the GI tract. So it'll be interesting to look at that in the future.
So there were a few questions that came in even before our conference started, if allow me to ask. Somebody wrote, for Katie Taylor's presentation, I often find that joint pain is a major factor in preventing me from participating in physical activity. Is IBD-related joint pain something that you've researched before? And if so, does exercise typically worsen those symptoms?
That's a great question. What we're going to find a lot of the times with physical activity and with IBD is that it's a personal experience. And more than anyone else that I work with in terms of creating an exercise plan, you need to really listen to your own body. And we do know that physical activity can be beneficial at reducing pain, both in the general population, and we have had research in people with IBD where physical activity has been beneficial in reducing pain and bodily pain. In fact, in my own research, there is a subscale to the short form 36, which is the health-related quality of life scale that we used, titled bodily pain, and we saw there were reductions in bodily pain for those that engaged in physical activity. But you definitely want to start off on that light intensity activity. And I titled this using something we termed the talk test, which if anyone's worked with anyone in a cardiac rehab setting, they'll be very familiar with. But essentially, it doesn't require these fancy watches or anything to monitor your heart rate. And if you're light intensity, you can both hold a conversation and sing along and jam along to your favorite song on your iPod or whatever you're listening to. And still be able to engage in that physical activity without running majorly out of breath. So these would be activities like walking or maybe some yoga, and then you can go up from there. And in terms of pain, if you are experiencing pain and you don't feel like on a given day that you can engage in physical activity, that's okay. Yoga is a great physical activity tool to be able to engage in, particularly if experiencing joint pain. We know that as we increase in age, we lose flexibility in our joints. This has an effect on increasing that perception of pain. And so yoga is a tool there to improve our flexibility. And so it could be really beneficial in that. So we do, in a roundabout way, see that physical activity is beneficial, but I would highly recommend starting at those lighter intensities. And it may take a couple of times and a couple of bouts of exercise to really see those benefits. We do see that people, even you and I, who may engage in physical activity very regularly. If I hike a hill today, I'm going to feel it tomorrow. And I'm going to feel it the next day. And I have to be able to adapt to that and know that in a couple of days with continued activity, and my body will start to adapt, and our bodies have a great way of adapting very quickly. And the same goes when we have IBD.
So the connection between the GI tract and the musculoskeletal system is obviously much less clear than in a condition like rheumatoid arthritis, where the target organ is in fact the skeleton. So there must be considerably more data about the effect of exercise on rheumatoid arthritis than there is inflammatory bowel disease in exercise. So are there any lessons from the rheumatoid arthritis literature concerning exercise that may address this writer's question about whether IBD-related joint pain is something for which exercise is good or bad?
Yeah, absolutely. There's not as much research as we would expect in rheumatoid arthritis. We have largely focused on those diseases that contribute to the kind of top 10 leading causes of death: cardiovascular disease, type 2 diabetes, strokes, and those sorts of things, and cancers. But I was very fortunate a couple of years ago to present at the American College of Sports Medicine, which is our national organization. And we have an exercises medicine themed section to that conference where I was presenting, and I was actually sandwiched in my poster session between a poster looking at physical activity and multiple sclerosis, and then physical activity and rheumatoid arthritis. And so it was a really interesting conversation that between people coming by our poster, we were able to engage in this conversation where we're all kind of in an interrelated ideas. And there is a lot of research that shows physical activity is beneficial to a person's quality of life and their perceived pain and dysfunction when they have rheumatoid arthritis. So I would say that that research is really promising to be able to translate that over to people with IBD. Again, it is starting at those low intensities. If you've not exercised in a while and you're feeling pain, don't feel you have to go out on a run. Just walking around the block for as little as 10 minutes will be beneficial, and working up from there. And that's really the key to helping somebody. All too often we see people want to engage in physical activity and they go so far beyond what they should start at. And that's where it is really important in prescribing the right mode, intensity, and time of physical activity. And another great resource would be something like swimming. I kind of keep that off my mind right now in this COVID era. Not many swimming pools, at least on my side of Washington, are open, but it is a non-weight bearing activity. And so that's really important. And we find, particularly in rheumatoid arthritis, in osteoarthritis, osteoporosis, anything that affects the joints and the bones and the skeletal system has real benefits when people participate in swimming. So that could be another activity, obviously, that has kind of other perceived barriers with someone with IBD. And so take that as you will. Swimming is something you enjoy and feel comfortable participating in. There would be an activity that I would certainly promote.
Another question comes from email, and this says, this presentation on the topic of physical activity was very insightful. I found Katie Taylor's description of Crohn's disease as something that can affect your digestive system from, quote, lum to bum, the highlight of the presentations. But the question I have, which I think she covered, but I want to be clear about it, is it seems helpful for IBD to engage in physical activity, and she was clear that it's okay that if you aren't feeling well to skip it, but is it okay to push yourself? I have a real interest in regaining weight and strength, so even though I may not feel like engaging in physical activity, is there harm or is there a benefit in doing so when you're feeling poorly?
Absolutely a great question, that I don't necessarily have the perfect scientific answer to. A lot of our research so far has been in mildly active disease individuals or individuals in disease remission. I will say from my own research that we did have participants across the full spectrum of disease activity, those that self-reported they were in a disease flare versus those in remission. And although that's maybe not the perfect categories to use. That's what we had access to in our survey. And what we found is that people, in terms of engaging in physical activity, did not differ in their physical activity levels between that disease flare and remission, which gave me some kind of comfort that we can actually engage in some level of physical activity despite being in a disease flare. So if you feel that you are capable of participating in physical activity and maybe push yourself a little bit on any given day, then that is okay. But you have to be okay with yourself equally on the other side of that. And I would say if you are going to kind of push it a little bit further, try and get some of those additional benefits, and you have a goal you want to achieve, then you do need to look after the body in other ways, making sure you stay very hydrated and making sure that you are kind of engaging in those activities that will help that maybe the joint pain that comes from it, as well as looking after the skeletal muscle. So plenty of stretching and those sorts of things. If you like foam rolling and those sorts of post-exercise activities can be really beneficial. But it is so very individual, and we don't know very much about exercising in a disease flare. I would say if you're in that situation and you have access, and this is a big barrier in terms of physical activity, but if you have access to activities like cycling, where you are controlling the GI tract, there's not as much kind of jostling and potential micro trauma because you are keeping it more stable. And you're moving those legs, you're working to an activity, it may be beneficial. Even the elliptical may be more beneficial, particularly, and this is more anecdotal than anything in basis of what we know of the mechanism, than hitting the ground running constantly. When you're on an elliptical, your legs actually are doing the work and you're getting those benefits of an aerobic activity, but you're not pounding on the ground. And as I said in my presentation, every time you pound on the ground, Newton's laws tell us that the ground pounds back, and that's what causes those micro traumas in the intestinal tract. And so if we can reduce that, particularly in a disease flare, and I think that would be very beneficial. In all the research that has been done, one of the biggest take-home pieces is that we have seen that none of the exercise interventions have caused any instances of the disease flaring, which has been a really positive portion of what we've seen. I will say anecdotally, I listed a few celebrity athletes in my presentation that have either Crohn's disease or ulcerative colitis. All of those, when spoken to, actually say that the sport is what kept them going because of the mental benefits of that physical activity. So even if you're feeling kind of crummy on a given day and maybe you are experiencing some GI distress, some of those symptoms, taking a walk, getting out, there's a multitude of benefits to getting outside aside from just the physical activity. The exposure to the sun, being around greenery, can all have benefits to our mental health as well. And so those, I would absolutely say, if you feel comfortable exercising, pushing yourself that little bit further, then you can try and see how you do, but do make sure you take in those kind of post-exercise activities, stretching, and staying hydrated and fueling your body appropriately as well. You don't want to get into a calorie deficit state as well too much.
Early on, you had mentioned that a lot of the research that's out there on exercise and health concerns conditions such as type 2 diabetes, heart disease, hypertension, things that are largely associated with obesity, for which obviously diet and exercise play a critical role in management. In inflammatory bowel disease, it's a bit of a different situation because, first of all, inflammation itself is very calorie inefficient. It consumes a lot of calories just to maintain the inflammation of IBD. But on top of that, the GI tract's role in absorbing nutrients is limited often in inflammatory bowel disease, and thus maintaining sufficient nutrition to keep up with protein needs, muscle building, maintaining weight can often be a major issue in patients with inflammatory bowel disease. And you mentioned yourself, the issue of hydration is also limited if the bowel is losing a lot of water and not very good at absorbing fluids. And so hydration is certainly during a hot time of year like this is often an issue for inflammatory bowel disease patients who are not exercising. So I wonder if you could speak a little bit about how exercise as a management strategy in inflammatory bowel disease can be performed in a way that's very careful to observe that sufficient nutritional and hydration needs are met during exercise so that people don't actually end up doing more harm than good to their physiology, just as a consequence of all the excess demand that the body generates during an exercise.
Absolutely. Everything goes hand in hand. Physical activity goes hand in hand with nutrition, and both of those go hand in hand into a treatment pattern if you're dealing with anyone with a disease. One of my biggest recommendations is actually working with your medical provider, and if they don't feel that they are qualified to provide that advice, if maybe they haven't had experience. I know that a lot of medical degrees now have an exercise physiology component, which kind of makes me grin ear to ear. We've talked a lot, Dr. Rob Salas has talked a lot about prescribing exercise, actually with a prescription pad and those sorts of things. But it is a conversation that has to happen. And if you've not been active in a while, and this is what we see a lot of the time, is people haven't been active, they maybe don't feel super confident about their body image. They want to get out and about, they want to try and overcome some of these symptoms, so they think they engage in physical activity. And then they don't necessarily have the resources to be able to do that, whether it's because science doesn't mesh well with getting that information to individuals, or maybe our medical professionals don't have the necessary training to do that. But even a conversation with your gastroenterologist and saying, I want to start exercising, they can put you into contact with either a dietitian in terms of that nutrition component, who will have the background in how to partner that with your exercise. And then many medical facilities now will have an exercise physiologist on staff. And I think that that's a great way to start, is actually seeking that professional advice as to what to do, creating a well-designed exercise program. And by that, having that flexibility in there, not in terms of stretching your muscles, but instead of stretching how it's going to work out. If you have an off day, if you hit a disease flare, if you hit a bump in the road, we all do that, IBD or not. We don't have a good day, whether it's because the air quality outside is horrific, or whether it's because you're not feeling it on that given day. And using those professionals, the same if you go into a gym, using a personal trainer for the first 8 weeks. Again, they may not have had training specific to IBD, but you know your disease. And that's a huge, huge win for you, that you can work in partnership with one another and say that this is what happens. I don't feel like it when I feel like this. Can we adjust those sorts of things? And they have the resources to be able to reach out to a lot of the professionals out there, the exercise physiologists who have had training in working with chronic diseases, that they can kind of start piecing together these ideas. I think it's more important than ever that we partner the two, whether it's for obesity, cardiovascular disease, or IBD. We have to work with nutrition in one hand and physical activity the other, and recognize that they do work in partnership. There's been far too many years that we have tried to say, well, physical activity is better than a good diet, and a good diet, weight loss is earned in the kitchen, and those sorts of kind of taglines that we've used, because really it has to happen in partnership to get the best benefit for the patient, for the person you're working with, and helping them along their way there. I will say one piece, this is where my interest really lies in resistance training. There's no research out there right now on this, so it is very much from the mechanism, but I think building muscle mass is going to be one of the most helpful ways for a person with IBD. It will go to some of those points that you were talking to there about kind of that loss of muscle mass that can be experienced with IBD because of the way the inflammation works, that perhaps if we can start rebuilding that, it can be beneficial in kind of reversing some of those negative effects that we've previously seen.
Well, thank you, Katie. I noticed that we're coming up on 12:30, so I'm fully 30 minutes over our budgeted time. My apologies, Jody, but I know that you had some closing remarks that you wanted to make. So before you do so, I just want to thank all of our speakers for generously donating their time this weekend, and more importantly, donating their time in the weeks preceding this to researching, assembling, and recording their videos, which will be a permanent resource for the Crohn's and Colitis Foundation and for the Northwest, or frankly, the nation's IBD community. And with that, I think I just hand it back over to you, Jody.
Yes, thank you all so very much. I've listened to a lot of education programs over the 20+ years I've been diagnosed, and I'm super, super excited to every time learn something new and get some valuable information to help me live well and help friends of mine that also have these diseases. So having a video library that's accessible for everybody on demand, as we mentioned, I think is going to be really, really wonderful for our patients and for their families. I think it's nice to be able to go get something right when you need it. I also am so thankful to all of our presenters for the time that they've spent today and in advance, to the Chapter Medical Advisory Committee for kind of thinking through how this could work in a new format. As you can see on the screen here, we couldn't do anything without our community partners. So I'm very, very thankful for their support. I saw, Karlee, do you want to mention something? Karlee is our Chapter Medical Advisory Chair, and I saw her raise her hand quickly, so we'll go ahead and let her chime in.
No, I was actually just saying I really appreciate how the theme of this conference has really been living well with IBD, and I think that's a little bit unique and very refreshing to hear.
Awesome. I agree. I feel like there's been some really good, useful information for everybody. So before we wrap up, I know we are past time. I do want to share a little bit about upcoming programs that the foundation has. On October 2nd, we will have our Epicure Gala. It's going to be a little different being online, but we really think it's going to be fantastic. There'll be Mike McCready and Ashley O'Connor McCready are being honored. And then Karlee, oh my gosh, I just lost your last name. I was thinking of the performer that's
You're thinking of Brandy Carlisle.
Brandy Carlisle. Yeah, so that will be super fun. So if you're interested, please check it out. You can access it from this website, or you can go to the Northwest Chapter page. On the same day, Hops and Vines is the traditional gala that happens in Oregon area. So if you're in Oregon, you can chime into that instead. There'll just be slightly different programs around it, but the auction for both is the same. So I'd encourage you to check those out. We're also running a program called Ultimate Team Challenge that starts tomorrow officially. It incorporates several different kinds of physical activity, from hiking to jogging, walking, biking, etc. So it's a really fun way. You can earn kind of a cool medal for swag. It's also a fundraising event. And then we have Spin for Crohn's and Colitis Cures. And this is just a really fun activity. I encourage you to join the virtual house party that will be December 5th. You can access that from our webpage as well. And then locally, we're hoping someday again we'll be able to be in person. But until then, we're going to keep building our virtual library. I would encourage you, if you have specific topics that you would like to have included in one of these events, to please send them to me. I will say that Katie is one person, for instance, that we were able to access because of a participant who shared her name with us through the Bellevue conference last year. So we do listen, we read those, we care. We will be sending out a survey after this meeting, and I would encourage you to fill that out and help us. Did this format work for you? Do you have ideas for a way that we could do it differently, knowing that we'll probably be in this environment for a little bit longer? And that's it. Go enjoy your Sunday. Thank you so much to all of you that hung out with us throughout. To the presenters, James, thank you so much for spearheading this with me, and have a great day.
Thank you, Jody. Although, Karlee, if you do want to play at the Epicure, you got 3 weeks to learn how to play guitar.
I'm not sure I could compete.
James will accompany you with drums.
Yeah, good.
Okay, guys, thank you so much.
Bye.
All right, thank you.